on the cost-effective techniques of meniscus repairs. We were all talking about meniscus repairs, but then it comes to cost. It's a big question mark. What to do? Because the area we practicing in, people don't have insurances in because they don't like spending on their insurances. And we are the surgeons. We would like to repair the meniscus. We would like to resect it. So before starting in my this cost-effective techniques slides, I would just like to put in disclaimer because I'll be showing various techniques to do that, but none of this technique is going to replace the devices or the instrument which are being specifically designed by various manufacturers. And these other techniques which can be used as an alternative to the standard techniques. So as sir talked about the techniques, there are various techniques. It's all inside out, and outside in. So whatever is the technique, we are orthopedic surgeons. So we should not forget the AO principles of fixation. Whatever we get, it should be anatomical reduction, a stable fixation. It should be reproducible, and we should be able to do early rehab, and then it should be of low cost. So generally speaking, all this, the maroon area will be posterior third, which is generally dealt with all inside devices. The blue area is generally dealt with inside out devices, while the green area, that is the interior part, is generally dealt with outside in devices, but it is not hard and fast that it can be used like this everywhere. Everything can be modified until and unless we are able to follow the principles. So directly coming on to inside out repair, which I think is one of the cost effective technique. So this is a small video which I will show when we are just looking into a medial compartment and we are doing a medial pie crusting. We just open up the joint and we can actually have a look at the good longitudinal tear of the posterior third, which is extending to the body, and then like debriding the edges. I come out with my zone specific inside out cannulas. One of my assistant passes in the needles. These are the preloaded needles, but how to do it without preloaded needles, I'll come, because that will make our repairs more cost effective as we have to take multiple bites into all these longitudinal tears. So once we are doing this, when my assistant is pushing in this needle, I just adjust my cannula over the tear so that I can have a good vertical stitch on the meniscus to give it a stable repair. So once this is done, when I pull them outside, I can see the meniscus lower leaf is lifted off. So I have to take a under surface bites as well, so that the undersurface also get the good compression. It's like putting in a plate on a forearm. When we do it on a tension surface, the other surface should not go apart. So same principles of orthopedics being followed onto the soft tissue. This guy had a double longitudinal tear. So I plan to put in one more stitch at the back to stabilize that tear as well. So this is the final repair. So the very important trick in this is do a good pie crusting, and we can see we can almost reach until like the root area or up to 10 mm. So this is the outside picture. So we don't give any posterior medial safety incisions, which was actually described. We just pass in the needles with, and we can switch our cannulas as well. So it is not always to use the zone specific cannula which are being marketed. This is how my staff is positioned. And you can see this, and I am holding a camera, and my staff is, one of the staff is holding the leg. So this is what is happening on the outside. I am positioning the cannula. This guy is coming in with a needle. This needle is without, this is not preloaded one. So it just passes it in. And I can see this guy passing in the needle thread and loading it. So this can be done without any preloaded stuff. So this needle can be used to pass in, and then we can even use a 2,0 ethibond, which is very cheap and cost effective, and it gives equivalently good stability to the meniscus. So that's how we can reduce on the cost while doing the meniscus repair. And if we switch the cannulas, it's not very always important that we should use a posterior cannula for the posterior part. Even we can use the middle one or the interior one, so that we don't injure the saphenous nerve on the medial side. This is very cost-effective technique for the medial side tears. The instruments used for this are the zone-specific cannulas. And of late, I borrowed a Jamshidi needle from my spine surgeon who was using it, and just found it out. I bent it, and I started using it for my meniscus spares as well. So this saved me on instruments as well. So these are the needles I was talking about. These are the preloaded needles which are available with the manufacturers. This is again a needle with a loop, which can help in reducing the cost because the threads are pretty long, and we can use it twice or thrice for the meniscus passes. So outside in repair, as the name says, you come from outside to in. This is mainly for the anterior horn, but can be used for a body. Posterior, it will be slightly difficult. So we pass into 18 gauge needles, one loaded with the Prolene and one with a looped nylon. Use a retriever or a normal mosquito artery to just retrieve it outside, and you just hold it and ask your assistants to pull it, because if you pull it like this, it can just cut the thread. So you and your assistant should coordinate in the movements while doing it. Then you pull it out. Now this will help in shuttling the thread outside. So this is happening on the outside. This assistant is doing his job well. The important trick in here is we'll just load the thread. He'll tighten it up, and these are the two knots which passes in before the actual thread, so that the passage through the skin is easy and it just doesn't get unloaded before it passes the meniscus tissue. So the instruments again are very cheap. You need to have two 18 gauge needles, an nylon, which can be then later used for the skin sutures, and a Prolene. Then comes all inside repair. So this is the technique which was described by one of the esteemed speakers. This is not exactly very cost effective because we have to spend some money on the instrument, and that doesn't come cheap. So you take a bite on the posterior part of the tear and retrieve a thread from the undersurface. We can use a crochet hook as well. We don't have a crochet hook, so I have to use a suture retriever. And then I make a pass in the near half of the tear. So there is some entanglements of the sutures. So I pull it out, make it through one pass of the tissue. I do it without any cannula. So this is a very low profile suture knot pusher, which comes from for AC type probe. So we just keep it and we don't throw it away. We sterilize it and use it for pushing in the knots and the meniscus. So these techniques come very handy while repairing the this type of tears, because on the lateral meniscus there's always risk of damaging the posterior neurovascular structures. So this is an actually all inside technique, but I'll not say this is very cost effective, because patient has to pay for this multiple loaded device which comes from another company. So you make multiple passes, but this has multiple implants. So we don't have to spend on various multiple devices. So single device will hold good for this type of tears. So as I said, when you are repairing the upper part, you can see the lower part lifted off. The lower edges are gone apart. To stabilize it, we have to always take some passes into the lower half of the meniscus to balance the repair. That will add on to the stability. And when you get these type of stable repairs, you can actually be very aggressive in the rehab. Not the weight bearing part, that will always take 4 to 6 weeks when you start weight bearing. Coming on to the root repair, when we started off root repairs, we never had this all inside antegrade devices. So this was a root which was torn. So we do a minimal reverse notchplasty, look into the posterior medial compartment. So and we do even a braiding of the bone, so that we can have some good space to repair this root. Then we have to clear off the cartilage from that area. And this is a jig which we had an old ACL jig. What we did it with it is we just cut the tip so that we can aim it for the meniscus roots. We drill from the below up from the tibia, and then comes my needle. It is loaded with a nitrinol wire loop, but you can use a prolene also to make a pass into the meniscus. And then we cinch two ultra high molecular weight polyethylenes, likely 20 or number 5, sorry, number 2 or number 5. So this is how we cinch it. And we don't use cannulas for this because that again adds to the cost. This is a second pass which we make into the root. An important trick here is again doing a medial pie crusting. So these cinches can be at times, there can be a lot of suture entanglement. So you have to be very slow in doing so. So wherever I'm using this nitrinol wire loop, you can use a simple prolene also. So that's how when we pull it down, we can see meniscus nicely sitting onto the root area. And that's the final fixation. So these are the instruments which are being used. This spinal needle, 18 gauge spinal needle is used for making the passes into the meniscus. This is a jig I was talking about. We just cut this tip so that I can easily negotiate into the tight area. And this button, which is very easily available, it's not very expensive, can be used to tie. The sutures can be used to tie on this button. So alternately, there's been technique which is called a bone bridge fixation. It's a implant-free double tunnel technique in which you make another tunnel. It comes from Nepal. So they also have to indulge in all these activities because the people, they have not have capacity to pay for the implants. So this is how they make a tunnel, retrieve the sutures to it and dye it over a bone bridge. So then a very important, which is a hidden lesion, it's called a ramp repair. So this is the area which we should always look into, the posterior medial compartment. So how to do that? We try to do it always inside out or with a lasso, but sometimes we don't have a lasso on a table or we don't have these devices. So what we do is we come from anterior with a long spinal needle. A posterior medial portal is very important. Our suture retrievers comes out from there and the prolene is pulled out. So you have to hold a prolene and your assistant pulls it out, otherwise it will cut through the prolene also. So you retrieve both the ends to the posterior medial portal, and then, as I said, these two knots will always help in making a pass to the meniscus. And then a number 20 ultra high molecular weight polyethylene is passed to the tissue. As this is cannula free repair, so we don't have cannulas here. We do a virtual cannula technique, retrieve both the ends to single pass so that there is no tissue bridge, and we then just repair it and pass in a standard knot pusher to tighten the knots. So that's the completed repair, and we can see it's a highly stable repair. So once we are done with the fixation, as we do with the non-union of the long bones, we have to do a bone grafting or augment our repairs. This is normally done when we do isolated meniscus repairs, because our associated repairs like ACL reconstructions, we get a lot of blood in the knee. So you want blood in the knee, we just do it from the ipsilateral foot. Before inflating a tourniquet, we get these type of clots. Of late, we just keep them in a container, and once we are done with the fixation, we try to put in these clots into the meniscus. So these are chemotactic, or you can do a bone marrow stimulation. The area in front of ACL, there's a lot of bone where you can just poke in few wires so that we can get good bone marrow growth factors from the notch, which helps in aiding the fixation in repairability of the meniscus, give some growth factors so that our meniscus repair doesn't fail. So we make multiple holes with a small wire. So to conclude, always follow the principles of fixation, and limited resources should not be a barrier in performing an effective treatment. Because I would say necessity is the mother of invention. So we keep on uh, devising all these innovative techniques so that we can help our patients who cannot pay and get a good effective treatment. Thank you.